Hi everyone, welcome to Medvocate's virtual shadowing event. My name is Annika and I am an events co-director for Medvocate. To those of you who are new here, Medvocate is a recently founded nonprofit organization. Our main goal is to provide opportunities for our members by connecting them to healthcare professionals as well as graduate school students so they can earn advice and more opportunities. Before we get started today, I just want to go over how to earn a virtual shadowing certificate. You must attend the full live session and earn a 2 out of 3 on the quiz that will be put in the chat at the end of the session. This quiz will be open for 30 minutes after the conclusion of the event, so keep an eye out. We also just want to learn a little bit more about you before we get started, so it would be amazing if you could participate in our icebreaker. The question for today is, what specialties of medicine would you like to see in our future virtual shadowing events? Please type your name and the answer in the chat. Today we have Dr. Shree Rao, who is an amazing ENT surgeon. She also has advanced training in rhinoplasties and facial plastic surgery from Singapore General Hospital in Singapore. She is here with us today to share her experience and present some case studies. Dr. Rao, thank you so much for agreeing to host one of our events. You can get started whenever you're ready.
Okay. Okay, is that okay? Are you able to see me? I mean my presentation?
Yes, we can see. Thank you.
Yeah. Okay. Okay. Hi everyone. I hope everyone is having a great day, and I hope you're all excited to learn something about ENT conditions and some treatment options. And I'm Dr. Shree Rao, Director and Consultant ENT, Rao's ENT Group of Hospitals, India. Well, a little bit about my training. I hail from India, and our medical system is a bit different from that of US and UK. In India, we get into med school after giving our national entrance examination. I did my med school in PS Institute of Medical Sciences, which is for 4.5 years. I passed out in distinction and was awarded gold medal by the then chief minister of our state. It's like equivalent to the governor of your states. And later, I completed my 1 year compulsory rotational internship from Narayana Medical College, where we'll be posted in different medical and surgical branches. Then I cleared my national entrance examination once again for my post graduation, and I opted for otorhinolaryngology, that is ENT, in Pratima Institute of Medical Sciences. I cleared my exit exam after 3 years course, and I stood as a state university topper in my state. Then I'm unable to. Okay, I was unable to change the screen. Okay, I did my senior residency in ENT head and neck surgery for about 1 year in government ENT hospital, which is a state-run tertiary hospital at Hyderabad. Then I did my fellowship in cochlear implant surgery for about 6 months at PD Hinduja Hospital, Mumbai. And currently, I have my private practice. I am the director and consultant ENT and head and neck surgeon at Dr. Rao's ENT Group of Hospitals, Hyderabad, as I told you earlier. I luckily practice along with my husband and my father-in-law, both of who are ENT surgeons. Well, today's outline in my presentation, we'll go through an introduction to otorhinolaryngology, and I'll make you walk through along with me about how to diagnose and manage a few cases in ENT, including a few short surgical videos, surgical clips. So, otorhinolaryngology is a surgical subspecialty in medicine which deals with both surgical and also the medical management of ear, nose, throat, and also structures which are related to head and neck. So, ENT surgeons deal everything in head and neck, excluding the eyes, and the brain. So a day for an ENT surgeon, I cannot specifically tell it's for an ENT surgeon, but for myself, for most of the private practitioners do have the same modality, I guess. So I start my day by 9 a.m. and as soon as I reach my hospital, I do my post-operative rounds, check on my post-op patients who were operated the previous day, and do the necessary dressings. Then I start with my OPD outpatient department by 9:30 a.m. and then examine a few patients till 12 noon. So between 12 and 12:30 I start my surgical procedures. An average surgical day includes fixing a hole in someone's eardrum, and then I move on to a sinus surgery, sinus operation, and then moving on to taking out a thyroid gland in some deceased thyroid patient. And once again on the same day I may perform a tonsil surgery or an adenoidectomy on a child. So they are pretty much diverse. And I usually plan my surgeries between 12:30 to 4:30 p.m. and then quickly I take a short break between 4:30 to 5. Then once again I come back to OPD and I start examining patients by between 5 to 8 p.m. So on a typical day in my OP, I attend to a whole age range of patients from a newborn baby up until a 95-year-old patient. And one more good thing about ENT or otorhinolaryngology is that we operate on a months old baby, like performing a cochlear implant on a baby who is born deaf, for a month's old baby, and we provide the sense of hearing for them. And simultaneously we also operate on an 80-year-old man, where we treat cancers which involve ear, nose, or throat. So it's really fantastic restoring someone's senses and curing their cancers. So that's a pretty good thing about ENT, what we feel happy about. So with this very brief introduction, I would uh, immediately crack into the case presentations. So coming to the case one, uh, a 25-year-old female presented to us with the complaints of left ear pain. On taking a detailed history, her ear pain started since 3 days, which was sudden in onset, and it was progressing day by day for about 3 days. And her ear pain aggravated on chewing or drinking water, on talking, on even at least even opening the mouth also. So it relieved temporarily on just taking some pain medication. It was very symptomatic. So anything you would like to ask in this history? So where can I get the chat box actually? Anything else you would like to know in the history? Chat box. Okay. I'm not able to see the chat box.
I can read them to you. So we have a couple of responses. Um, one response is, what
Yeah.
kinds of activities did she do prior to the ear pain? So
Yes.
they give an example of swimming.
Yes, that's a pretty good question.
Another one was the woman exposed to any water, which is similar.
Yeah. How old was she? Was any ringing ears also a symptom? Yeah, it's pretty good. So most of them are in track then. Okay, so in any history, taking a detailed history is really important to arrive at a probable diagnosis before proceeding for examination and further investigations. So most of the time, half of the diagnosis will be understood from the history itself. So once again, coming back to this patient, we usually ask whether she had some similar episodes in the past and yes, I got the answer from someone. Did she have any cold symptoms. Yes, and she had a history of upper respiratory tract infection a week ago, which is quite relevant in this history. And there was no history of trauma, ear discharge, fever, giddiness. And there's one more answer, that whether they have any dental problems. Yes, that's also very much relevant to this question. It's from Gandhi Mathi Sarvanan. It's quite good. Excellent, excellent. And um, she did not give any significant past medical and surgical history. So once again, okay. So we started with our routine ear, nose, and throat examination. And this is me in my OPD room. And the one who is sitting opposite to me is not a true patient. She is my PA. She just volunteered for being a practice patient. So usually we do not wear this amount of stuff on us, or this amount of protective gear on us. But this is just taken a few days ago, and we are looking so bad. And I place this video here in order to make you feel that you're truly shadowing an ENT surgeon, and hope this helps. And I guess it's already being played. And this is how we put on the headlight, and we do a physical examination this way. On examination of her ear, the ear pinna and the surrounding area appeared normal. And on nose examination, we call it as anterior rhinoscopy, where we put on the headlight and see the nose. There was some nasal discharge on the left side. And on pressing on the cheeks, we check for the sinus tenderness also. So on pressing on the cheeks, she had problem on the left side of her cheek. She felt tenderness over there, and her oral cavity and oropharynx appeared normal. So there was one more answer stating that whether she had dental infections. So in that way, we need to check the oral cavity also. And on head and neck examination, there were no palpable lymph nodes. And for more in-depth examination, we shift to endoscopy. And here I'm performing an ear endoscopy on a practice patient. We examine the external artery canal and also the eardrum. That's the eardrum, how a normal eardrum appears like. Now, this is the autoendoscopy video of the right eardrum of our patient, of the right eardrum. So this is not the decision, but by the way, this is how a normal looking eardrum looks like. So it's a perfectly normal eardrum. So in the left ear, there is a mild cerumen on the outer side, but what do you think has happened to this patient's eardrum? I'm sorry, I'm pretty bad at reading the chat. Okay.
Would you like me to read out some of the
Yeah,
answers?
yeah,
People are responding.
I
Yeah,
really
okay.
appreciate that.
Okay. People are saying infection, inflammation, swelling. Those are some of the responses we have.
Yes, yes. So you're absolutely right. So there is some amount of infection. So you can clearly see that. How to go to the previous slide? Yeah, you can clearly see that her eardrum is entirely bulged. You're able to see that, right? It appears entirely bulged, as if the pus is under tension with surrounding leash of blood vessels, hyperemia. This is called infection within the middle ear. Okay. Yeah. Then we proceed with the nasal endoscopy, and we call this as a diagnostic nasal endoscopy. Now, we are passing the endoscope through the right nostril now. We can see the septum, which separates the partition wall between right and left, and this is the flesh called the inferior turbinate. So that's the nasopharynx. That's from where usually the COVID swab is taken right now, because we are all in the COVID era now. So we need to make sure that we do not cause any injury to the surrounding structures while performing this diagnostic nasal endoscopy. Of course, we give a numbing spray and a decongestant spray, which makes the patient even more comfortable and during the entirety of the procedure. Then we pass the endoscope through the left nostril, and we can clearly see that there is some amount of pus collecting over in the nasopharynx, and this is the eustachian tube, and there is clear pus collecting in the eustachian tube also. So why do you think we need to examine the nose and also the throat of a person who has come with the ear pain? So I guess most of you know the question. That's why some of them answered me that we need to check for the dental thing. There's some infection going on. So I'll straight away go to this. So here you can clearly see that all the structures, this ears, nose, and throat, all are interconnected. Eustachian tubes are which lie at the back of the nose. You are able to see at the nasopharynx. They connect to the middle ear in this way, like this. So the infection from the nose, it clearly spreads into the lip. If you observe, this patient had left ear pain, and her left ear was entirely filled with pus, and similarly her left side nasopharynx was entirely filled with pus. So the infection has been spreading from the nose into the ear via the eustachian tube. So similarly, some people have tonsils which are being infected, and they have some ear pain. So we need to check the throat also, because they have a common nerve supply. The tympanic branch of glossopharyngeal nerve supply is the ear also. So that's the reason when we have some tonsillar infection in the throat, also we may have some ear pain. This is called referodalgia. And even minor tongue ulcers, which are any mass lesion which are present at the entrance of your food pipe or the piriform fossa, also triggers ear pain. And that's the reason it's really important for us to check ear, nose, and throat together for any patient, whoever has come, whoever visits us. So what do you think is diagnosis is? As you came to know, it's an infection. So this we call it as acute otitis media. It's an infection of the middle ear. Most of you have answered this, I know. So it's an infection of the middle ear, and we need to know why is that being infected. It's infection because it's spreading from the nose. It's not somewhere from the dental, or it's not from the nose. It has been spreading to the ear. And because it's an infection, we manage this condition medically with some oral antibiotics, some oral and nasal decongestants, and some mucolytics, and some symptomatic pain medications. And we review the patient after 10 days by when she would have completely recovered. Okay, now a question for you all now. What do you think this is? This is really interesting. I wish I could read the chat. Okay. Here you could
We have an
see,
sorry.
sorry.
Yeah, we have an answer saying a perforation.
Yes, excellent, excellent. That's true. So there is also some pulsatile discharge. I'll just put it back for you. There's also some pulsatile discharge which has been I'll just play this once again for you. Yeah, you can see as if it's like a heartbeat, and it's pulsatile. It's coming, the pus is coming out from the perforation. You're able to appreciate it, right? Yeah. So if the previous condition, this is this is also acute otitis media. So if the previous condition, acute otitis media, is not treated with medical management, like giving some antibiotics, some mucolytics, some decongestant, the eardrum ruptures because pus is under extreme pressure, pus is under extreme tension, and it ruptures, causing a perforation in the eardrum, and it causes pouring out of discharge, the pus as seen in the video. So never neglect the ear pain. Okay, I'm sorry, I'm very poor in this technical stuff. Please excuse me. Hope you're understanding the thing. Okay, so now I have few more questions for you. So, Anaga, is it possible for you to just read out the mm, answers whichever they are giving in the chat, because I'm unable to read the chat. Okay, right now I'll be popping out some questions
Sure.
for the students. Okay,
Okay.
okay. Moving on to differential diagnosis now. So differential diagnosis are those like the other probable diagnosis which present with more or less a similar complaints like pain in the ear, which this patient experienced. Okay, I'll show you a normal eardrum which has been popped up here. This is how a normal eardrum looks like, so that you can compare with the disease things. And what do you think this is? I'll give you some options then. Okay, what do you think this is? A automycosis, or automycosis is fungal infection. Auto is ear and mycosis is fungus, some fungus which is growing in the ear. Or B, a grommet, a ventilating tube.
Most people are answering A.
Wow, good. Yes, the option is automycosis, the fungus which is growing there. So most of you pre-meds, I think you would have been majors in biology itself. You can see the fungus which is growing on here very prominently, the hyphae and the spores. So the spores are entirely black in color, indicating this is some Aspergillus niger, combination of Aspergillus niger, and some amount of white. So this also indicates some candidial infection. So in toto, it's automycosis of the ear. So we give some topical antifungal. First, we need to remove the disease or the fungus, and then we ask them to apply some topical antifungal ear drops and keep the ear dry. So that's how we manage that condition. Okay, I have one more question. What do you think this is? Most of you can easily answer this. That's why I'm not giving you any options. You guys are quite intelligent, I guess. You're answering all the questions. Any answers?
We have bleeding as an answer.
Yes.
Yeah, rupture of a blood vessel, burst eardrum.
Yes. That's excellent. That's a traumatic, that's a burst eardrum with some amount of blood. So this is called traumatic perforation. There's a clear-cut perforation or the hole in the eardrum, but we can also see some blood staining. So this we usually consider it as an earbud injury or some thigh slap injury, which patients do not agree for that. They just tell some stories, but that's the usual thing which happens. So patients do present with ear pain, they do come us, and when we put an endoscope, this pops out. This is a traumatic perforation. And then I have one more for you. What do you think this is? This is similar to that, so I can just tell you this is once again trauma. You can see very prominent blood entirely getting collected in the external auditory canal. As I told you, in an endoscopy we not only see the eardrum, this eardrum, we also see the external auditory canal. So the external auditory canal, this is followed by a road traffic accident. This lady, she had a very bad RTA and she had bleeding in her ear, and even she had some amount of hearing loss, because even the bones which are responsible for her hearing were being damaged. So this is some trauma to the EAC and along with some traumatic perforation. Okay, what do you think this is? This is quite easy. Most of us would have suffered at least once. So I gave you options also.
Everyone is answering A.
Okay, so is the swimmer's ear. The answer is swimmer's ear. Okay, this is called otitis externa. Also, any kind of infection in the exploratory canal is called otitis externa. So, in this situation, this patient is a very good swimmer, and we call it as swimmers here. And this patient, this otitis externa, they have severe excruciating ear pain because the temporomandibular joint just lies anterior to the canal, and as and when they open the mouth or they speak, they have excruciating ear pain. So they present with similar complaints what this earlier patient presented. So this is one of the very good differential diagnosis for pain in the ear. You can also appreciate that this is because of the extreme infection which is in the outer canal. Okay, we are not supposed to put any earbuds or once again cause some trauma to this. Okay, here I don't think most of you can answer this condition is called cholesteatoma. It's a disease which has bone eroding capacity. Okay, thank you. Which has the capacity to erode the bone. So this bone erosion and necrosis of the bone of middle ears cause severe pain, and sometimes they may also land in complications like facial palsy of the involved side, and they may also experience very bad dizziness. So that's too much for you guys, but this is we usually call it as cholesteatoma. Okay. Okay, I think I'm running late with this. Okay. I'll go with case two. A 27-year-old male presented to us with complaints of right ear discharge. And on taking a clear history, the patient had right ear discharge on and off since several years. It was insidious in onset, and it was progressively worsening day by day. The discharge was increasing. The ear discharge aggravated when the patient had common cold or any upper respiratory tract related infections, and the ear discharge it temporarily relieved on taking some ear drops, topical ear drops. And this discharge was also associated with some amount of hearing loss, which was progressively worsening. Even the hearing loss was progressing day by day for him. The patient had no history of ear pain or trauma or fever, giddiness, and he had no significant past medical or surgical history. On ENT examination, the ear pinna and the surrounding area appeared normal, and on nose examination through anterior rhinoscopy, it appeared normal, and there was no sinus tenderness, and the oral cavity and the oropharynx appeared normal. Head and neck examination was also absolutely normal. There were no palpable lymph nodes. So, here are the endoscopic pictures. On autoendoscopy, there was mucopurulent discharge entirely. And then after suction clearance, the picture was like this. Nose and throat was absolutely normal, and the left ear was absolutely normal once again. So here you can clearly see that the patient has a perforation in the eardrum, because most of you have answered the previous thing. So it's quite easy for you guys what to know what the diagnosis is. That's why I just keep the simple straightforward case. But here I'm concentrating more on the hearing also. Okay, that's the reason. So after we check the autoendoscopy, all the ENT surgeons, we do some clinical tests for hearing also. uh, these clinical hearing tests include Rennie's and Weber's tests, and we usually do with this with the help of a tuning fork, a vibrating tuning fork of around 512 hertz frequency. And the main aim of these tests is to mainly differentiate whether the patient has a conductive hearing loss because of the erosion of bones or any other thing, or is the patient having some sensory neural hearing loss which is related to the nerve deafness. So this is really really important for any ENT surgeon. So this is how we do a Rennie test. We first inform the patient about the test what we are going to perform, and then we place a vibrating tuning fork in front of their ear and then at the back of their ear. on the mastoid bone. They are advised to tell us which sounded better, the front one or the back one. That's how we do. If the patient tells us that the patient is able to hear the front one better, it indicates Reni positive, that their air conduction is better than the bone conduction. They are able to hear it properly. So this is Reni positive. If the patient tells us that they are able to hear the back one better, with the one which is on the mastoid bone better, this is called Reni negative. It indicates that the patient is able to hear better with the bone conduction rather than the air conduction. It clearly tells us the patient has some amount of conductive hearing loss, and this is we call as Reni negative. And we perform this test on both the ears. In our patient, the patient is having Reni negative on the right side, on the perforated eardrum. We have seen that the patient has eardrum perforation on the right side, and he has some amount of conductive hearing loss also on the right side. So from the Reni test, we came to know that the patient is having conductive hearings. Then we proceed with the Weber's test. We place a vibrating tuning fork on the middle of their forehead as shown, and they should be able to tell us which side they are able to hear better, on the right or on the left. Normally they should be able to hear it in the center or in both the ears. This is called Weber centralized. But in case of conductive hearing loss, it is usually lateralized to the worser ear. So in case of sensory hearing loss, it is lateralized to the better hearing ear. So in our scenario, in our patient, the patient is having a perforation in the right side. So you need to remember that all the time. And the Weber's test came out to be lateralized towards the right. So the patient has some amount of conductive hearing loss towards the right ear. And also the patient has a perforated eardrum, which is discharging. So not only the perforation, he also has some amount of conductive hearing loss. Okay, so then next we proceed with the investigations. In the investigation, only after the clinical investigations are done, we send the patient for both audiological investigation and also radiological investigation. Audiological includes the pure tone audiometry and the impedance, which are the gold standard tests in hearing evaluation. Okay, and these are done by trained and certified audiologists. So I just wanted to show you, I'm not going in detail into this pure tone audiometry, but because this is a shadowing session, I truly wanted to show you what's happening in an audiometry room also. So this pure tone audiometry is usually done in order to check the type and also the degree of hearing loss, the amount of hearing loss. With the clinical test, we'll be able to just assess whether the patient is having some conductive or sensory neural. But this clearly tells us in number that the patient is having some amount of some 58 decibels hearing loss or 30 decibels hearing loss in that way. So in this pure tone audiometry, uh, pure tones are presented to each ear individually at different frequencies. So you're able to see. So whenever the patient is able to hear, she raises her hand or she indicates that yes, I'm able to hear. And air and bone conductions are separated, are checked separately, and the entire thing is being plotted on a graph. And we finally obtain a pure tone audiogram. Then we go ahead with the impedance audiometry. And this is an objective test. What do I mean by objective test? It indicates that it can be done even on kids. So the patient has nothing to do. We just place a probe here and it directly gives us the result. These two are the gold standard tests in hearing evaluation. So what does this test do? This test mainly helps us to find the compliance or the stiffness of the tympano-ossicular system. Thus, it assesses the status of the middle ear. So in our scenario, the patient has a perforation in the eardrum. So there will be no seal. So it will be a flat graph with the impedance indicating that he has a perforation. So that's how this impedance helps us. So these are the graphs. This is how we plot on the right here that he has some amount of hearing loss, conductive hearing loss. And this is the impedance audiogram. This is how we give the report. Right side, he has a B type because the seal could not be obtained. I'm once again not going in details into this because this is just a orientation class. And this is HRCT, or high resonance computed tomography imaging of the temporal bone. We usually do this in order to identify the intactness of the ossicular chain and whether the disease is present in the mastoid bone or not. So that's importance of the temporal bone. And coming to the diagnosis, it's a straightforward thing that the patient has a perforation in the eardrum with discharge, and we call it as chronic suppurative otitis media. Otitis media, once again, there is infection in the middle ear, which is a suppuration, and this has been happening since years, so this we call it as chronic, along with and with a central perforation. And also the patient has mastoiditis, infection within the mastoid bone with some amount of conductive hearing loss. So how do we manage this case? So we do a cortical mastoidectomy where we drill out the diseased bone, and we do an ossiculoplasty where we repair the hearing bones or the damaged bones, and then finally do a tympanoplasty, or we repair the eardrum. So this is me in my OR performing on our patient. This surgery is done under local anesthesia with the patient lying down under the microscopic vision. And the local importance of local anesthesia is that the only the part whichever is being operated is being numbed with the help of injections. So after local anesthesia is given, I give an incision post orally behind the ear, and with the help of cautery, I elevate the flaps clearly, and then I harvest the fascia, which is used for closing the eardrum hole. Then the deceased mastoid bone is drilled away as shown. This is called drilling of the mastoid bone. So you can clearly see the disease in the pus, which is in the mastoid. And now you're able to visualize the hole in the eardrum very clearly. That's the hole in the eardrum. Then the graft which is being harvested earlier is taken, and then it is tucked under the perforation. From here, I kept the video under fast mode just to speeden it up. So that's the ossicle which is being seen. And yeah, this is the final picture. The entire perforation is being closed. And finally, I apply some sutures. Okay. And now coming to the differential diagnosis. What are the probable diagnoses which present with more or less similar complaints like the one with shown previously? So this perforation. So here in this perforation, we can clearly see a larger perforation in the eardrum with the exposed ossicle. This is one of the hearing bone called malleus, the first hearing bone. And these patients present with an increased amount of hearing loss in comparison with the previous patient, which has a smaller perforation. Even though the eardrum is dry because this patient was managed on antibiotics, so this is dry. But once again, when we withdraw them from antibiotics, they start discharging, and they also have some amount of hearing loss too. So in the third picture, we can see here that the patient has an intact eardrum, but there are some granulations causing it to actively discharge like our previous patient. And this condition is known as granular meningitis. And once again, this is too much for you, but I'm just giving you the differential diagnosis because once again, when a patient comes to you with discharge, you're not supposed to think that the patient just has some hole in the eardrum and that's the reason he's just discharging. Some patients can be medically managed also, like these conditions. Okay. So now coming to the case 2, I think I have 20 more minutes left. I'll just speed it up. Okay. A 30-year, well, this is really an interesting case presentation. Uh, this 30-year-old female, she complained that she's able to hear some mosquito flying sounds in her ear. She wanted me to remove it. And in her history, she clearly stated that this started a few days back and it was insidious in onset. It was associated with ear block too. She uh, also gave some a history of similar complaints in the past too. And there is no history of ear pain, trauma, fever, giddiness, etc. And there is no significant past or past medical or surgical history. And now this is autoendoscopic picture of her. I just kept the video under loop mode so that you guys can just appreciate it and tell me what's happening there. You can clearly see the fluid in the middle ear and also the air bubbles which are here. They're just moving within it. It's very common for adults to complain this ringing sounds in the ear and block sensation in the ear whenever they have this fluid collection within the middle ear. So first case which I presented, there was entirely pus in the middle ear, and some people they just have some fluid collection within the middle ear. And these patients do not have much of pain, but they have some buzzing, chronic buzzing sounds, and some block sensation. And it took some convincing on my part to explain the patient about this. On nasal endoscopy, polyps were visualized in both the nasal cavities. So these are the polyps, which is suggestive of some allergic etiology. So these are the polyps which are visualized. And once again, we did the normal investigation. Of course, we do Rainy, Weber, everything. And finally, we jump into the investigation. On pure tone audiometry, there was bilateral conductive hearing loss. And on the impedance, there were bilateral B grafts. And the diagnosis, this condition is called glue ear with nasal polyposis, which is extremely common, very extremely common. Glue ear is very common in kids, but in adults also glue ear happens, and this is because of the allergic etiology which is happening in the ear. This is also known as non-suppurative otitis media or secretory otitis media, where there is a clear-cut non-infective fluid collecting in the middle ear. So these patients do not have any ear pain, but they complain of ear block. So how do you manage this case? We manage this surgically. We do a myringotomy, or an incision in the eardrum is called myringotomy. And then we, with the help of a suction, we suck away the entire glue in the middle ear. You can see how thick is the glue. It's like a tug of war kind of condition. And we also ensure that the entire glue is sucked out. So the final contents are also being sucked out. Okay. And finally, we place, that's a grommet, the ventilating tube, which is placed exactly in the incision, which is made earlier in this eardrum, this providing ventilation for the middle ear. Simultaneously, we also perform endoscopic sinus surgery and polypectomy, addressing the root cause for this middle ear infection called the glue ear. Okay, so we can see different types of glue formations in the middle ear, and they take different shapes. They are very emotive, and sometimes they also can express as love. So you can see this collection of fluids. So all these are different types of glue ear, where you can see different fluid collections with air bubbles. We really enjoy seeing this glue ears. Okay, what are the possible diagnoses? Once again, questions for you. These are quite easy. So what do you think is the answer? Is it cerumen or stone in the ear? Oh, most of them are
We're
answering.
getting, yeah. Hmm.
I
We're
have
getting
the,
A.
yes, excellent, excellent. That's cerumen. The answer is A. Okay, one more. I have options for you here. I have clearly shown you how a grommet looks like. So tell me what the answer is. Is it grommet or a tympanosclerosis? Wow, I can get the answers here. Most of them are telling me B. So it's tympanosclerosis. So this is the tympanic membrane. This is the sclerotic patch which you can see. The answer is tympanosclerosis. And yeah, what's this? So these are the options. Someone has already answered osteoma and oh my god, all are answering the right answers. The answer is B, osteoma. Osteoma is some bony growth which is arising from any of the walls of the external artery canal. Here you can see that the a bony like projection is arising from the superior wall of the external artery canal. Okay, perfect. So what do you think these berries are, little berries are? I have given you a few options also to work on. Little berries. Excellent. Once again, the answer is A. I have 15 minutes more left. And these are the polyps within the ear. Polyps are nothing but the organized granulation tissue. There's one of it is arising from the middle ear, and one of it is arising from the superior wall. So this is both are unsafe CSOI. So even these patients experience ear block like the patients with the glue ear. So all these are the differential diagnosis. Okay, coming to the case 4. A 2-year-old baby was brought to me with a single-sided nasal discharge. It was sudden in onset, and the child had no history of cold or cough. Now, a single-sided nasal discharge, and it was sudden in onset, no history of cold and cough. Does this ring any bells? Do you suspect anything? Would you like to probe parents about anything else in the history? Okay, we usually ask the parents whether the baby has kept any foreign body in the nose, and the patients I mean the parents, they were not very sure, so we had to do a nasal endoscopy. This nasal endoscopy was done under short sedation, and I visualized a peanut deep in the nasal cavity. On removing the peanut, I noticed some blood staining and also some granulations, which is indicative of foreign body reaction, which happened in the nose, which explains the nasal discharge. And I endoscopically also examined the other side nasal cavity. So there are no leftover foreign bodies. Similar nasal endoscopy was done on a 5-year-old child, and sometimes they do cooperate in the OPD itself. We just give them some numbing spray and decongestant, and once again the diagnostic nasal endoscopy is done. In this case, the child pushed a button into her left nose. She also had nasal discharge, unilateral nasal discharge. First we had to suction clearance, all that, and then proceed with the endoscopy. That's a button. Children can sometimes be extremely mischievous. So coming to the next case, a 40-year-old female patient presented to us. I have 10 more minutes. Presented to us with some throat. Do you mind if I take 5 more minutes of your time, because I have 2 more cases left? Is that okay?
Sure, that's no problem. Yeah, thank
Okay.
you.
She presented to us with throat pain, and it was a pricking sensation in the throat since one day, which was sudden in onset, and the pain started after consumption of fish. What else would you like to know in this? I usually, as a doctor, we need to ask because it is after, yes, some of them are typing the answers also for an object or where exactly is the thing. We would like to know the exact site of the patient's pain because she's very clearly telling that she consumed a fish. So, putting a fish bone in the mind, we need to ask where exactly is the site of the pain. So we did an endoscopy immediately on her throat after giving her a numbing spray. So this is the tongue. We kept the endoscope through the throat and we were able to visualize. Are you able to visualize the fishbone there? It's a transparent one. So that's the fishbone. That little transparent one is the fishbone, which is just stuck at the base of the tongue. This is a very basic instrumentation. It's just a forceps. We put an endoscope and then we remove. So usually we ask where exactly is the site of pain, and the patient herself told that she consumed fish and immediately after, because she's an adult, she can give a very clear history. So foreign bodies can sometimes be taken very easily in this manner. So it's really important to know the exact site or location. Now, moving on. So, this is the last case for the day. A 27-year-old female patient presented to us with complaints of hoarseness of voice. She had this hoarseness in her voice since 6 months, which was progressively worsening. She experienced episodes of complete voice loss in between also. She does not give any history of sore throat or dysphagia. Dysphagia is difficulty in swallowing. Odynophagia. Odynophagia is painful swallowing. And dyspnea. Dyspnea is difficulty in breathing. So right now, most of the COVID patients are lining up with this dyspnea. So that is what is called as dyspnea. So she does not give any such thing. She just tells that there is a change in her voice. There is some hoarse voice which is happening. uh, we usually probe her whether she has any excessive usage of voice present. Yes, and she herself, she admitted that she has uh, excessive usage of voice, and there is no history of upper respiratory tract infection or trauma or fever. And her social history, she's a homemaker and she's a mom of 4 kids. Imagine, mom of 4 kids, and you can clearly understand the situation. There's no history of, she doesn't have any history of smoking, and no past medical or significant past medical or surgical history. On ear, nose, and neck examination were normal, and her voice was rough and airy. It's really important for doctors to assess the voice when they attend the OPD, because some people, they just tell that the voice is rough or it's different, but we need to assess. Actually, some of them may have some breathy voice, or some may have spasmodic voice, or some of them may have strained voice. So that assessment should be done. So this is too much for you, but we also assess the voice in OPD. That's the reason I just kept that there. Then we further investigate, because this is something related to the throat. We do a flexible nasolaryngoscopy. So before okay, before I show you how a flexible nasolaryngoscopic picture of this patient looks like, I would like to show you how a normal looking larynx would appear, and I would like to appreciate you to appreciate the anatomy. So here I pass the flexible endoscope all through the nose, through the nasopharynx, and now we are visualizing the larynx from above. So this is the epiglottis, and these are the vocal cords which are responsible for the production of voice, and these are the aryepiglottic folds, and these are the entrance of a food pipe, pyriform fossa. All this needs to be looked at. This is the base of the tongue, and this is the valvula. Okay. And this is how the vocal cords vibrate. I'm sorry, that's a very bad voice. Here you can clearly see the mucosal way which is being transferred. Okay, so this is the endoscopic picture of our patient's vocal cords. She uh, had this history of hoarseness of voice. So what do you think is wrong with them? Any answers? What do you think has happened to these vocal cords? Yes, injured, bleeding, overused. Yes, the option is bleeding. The patient had, because she's a mom of four kids, she overused her vocal cords, and sudden raise in the voice pitch or sudden abuse of the voice results in hemorrhage. There'll be micro tears which are happening in the vocal cords like any other muscle which is being overused, and it causes bleeding. And this is called hemorrhage within the vocal cord hemorrhage. And you can clearly see a diffuse blood collection under the surface of her left vocal cord. And this, as I told you, this is vocal cord hemorrhage. And I kept the patient under observation for about a few days, and I just checked whether they would spontaneously resolve. I kept the patient on some medications, PPIs, and some anti-inflammatory drugs, and some strict voice rest. And on 45th day, I did a repeat endoscopy, and I could clearly appreciate that the blood collection, although partially resolved, was organized into a clear-cut polyp. Okay, here you could see the entire bleeding through the vocal cord, but the bleeding has localized very clearly, and this is called a hemorrhagic polyp. And the patient was really apprehensive about her voice, and looking at this picture, she was even more tensed up. So finally, I proceeded with the microlaryngoscopic laser excision of the polyp, of the hemorrhagic polyp. And this is a final endoscopic picture which is just taken 20 days after surgery. She'll do even more, much better. This is the removed thing. Okay. And this is a microscopic view of the larynx. The previous one was the endoscopic view, and this is a microscopic view. We can clearly see the laser beam. I do with CO2 Acupulse dual laser. So it's kept in a straight pin mode, and the laser beam is pointed over the vocal cord, and precisely we laserize the edges as shown. Entirely we laserize because this is a hemorrhagic polyp, it may once again bleed. So we first laserize the edges, and finally we catch hold of the polyp, and then we remove it slowly. The edges may just be cut that way. That's a removed polyp. And this is the final picture you can see. That's the final picture after immediate excision. So I have two differential diagnoses for you here, which present with the same hoarseness of voice. So there are many other vocal cord lesions which produces some similar things, but I'm just popping out a few for you. What do you think has happened to these pretty little vocal cords? Okay, what do you think that is? Yes, someone in the app just, is that the gauze to catch any fluids? Yes, that's a gauze to catch fluids, yes. And any answers for this? This bump, this tiny little bump? Yeah, polyp, abnormal growth. Yes, that's definitely an abnormal growth. The small bump on the right vocal cord, it's very precisely organized, and we call this as a vocal cord cyst. Okay, this vocal cord cysts are the fluid filled sacs. See, if you really look at the video which is being played, this is clearly round and is into the vocal cord, into the muscle. So it's beneath the epithelium and very clearly organized. So this condition is known as vocal cord cyst. Sometimes this kind of stuff, they usually appear on the other side vocal cord also. We should not get confused this with some vocal nodules, because vocal nodules are the ones which are produced on individuals who speak a lot, but they are usually bilateral because of the chronic beating up of the vocal cords happening, and they are clear callus like growths. But usually the unilateral one, uh, and the appearance of this clearly tells us that this is a vocal cord cyst. And someone mentioned me it's an abnormal growth, and this is for you guys, whoever have given me the abnormal growth. So what do you think has happened for this person? So this is the right cord and this is the left cord. Yes, someone has already given me the answer. So this is the picture, the endoscopic picture. You can see one of the cord is pretty normal and the other cord is entirely, you can see a mass. This is an ultra-proliferative mass on the vocal cord, and there's a clear-cut suspicion of carcinoma. And the good thing is, both the vocal cords were mobile, so this patient has pretty much come at a very early stage. So as the earlier the diagnosis can be made, the better the prognosis can be, because even the vocal cords are mobile, he just lands up in hoarseness. So we just need to remove the tumor entirely, very precisely, with a half centimeter of tumor margin, and the patient will be pretty much good. He'll be out of danger. Okay, that's it. Any questions? Any questions I would love to take?